Okay, we'll make a start now, I think. So let's see if I can share my screen and we'll start. Yeah, well, welcome everyone. I was wanting to talk about diabetes in children today because well, we saw a child at PMGH this week with diabetic ketoacidosis, and I thought it was a good opportunity to really talk about the acute management of diabetes and how you transition to sort of more chronic management. So we'll start, I think. Yeah. Okay. So this was a 7-year-old boy. This is not exactly his presenting problems, but he'd been unwell for somewhere between 3 and 6 weeks with weight loss and lethargy, and then more recently respiratory distress. And this is very similar to the young boy's blood gas that we saw this week. His pH was 6.9, so a very severe metabolic acidosis. His CO2 was only 11, which means that he's breathing very fast and blowing off carbon dioxide and hyperventilating really to a very low carbon dioxide level, the normal being 35 to 45. His PO2 was fine, of course. Most children with diabetes don't have a lung problem, even though they're breathing fast. It's nothing to do with their lungs. His bicarbonate was extremely low at 2, the normal being 18 to 25. And why is that? Because you've got a severe metabolic acidosis, and the bicarbonate tries to mop up all the hydrogen ions and goes very low. And the base deficit was very large, so -22. His sodium when he came in is 128. His potassium was 5.6, but all children with diabetes they may come in with a normal or even a high potassium, but their potassium level is in their body, their total body potassium level is always very low. And the urea and creatinine in this child were a bit elevated in the first 24 hours. And that's actually quite common in children with diabetes. The other thing that I haven't put on the slide is that his white cell count was over 25,000. And that is also common in children with diabetes. So often in the last 24 hours before a child presents with diabetes, they get a neutrophilic reaction. And sometimes that can be interpreted, not misinterpreted, but interpreted as being that they've got sepsis or they've got some severe infection, when in fact it seems to be a part of diabetic ketoacidosis. So this boy had a metabolic acidosis, which was poorly compensated. Even though he was breathing very, very fast and very deeply, he only breathes down to a CO2 of 11. Still, his pH is still 6.9, so he's still got a severe acidosis. It's not very well compensated. You can calculate from the blood gas, you can calculate his anion gap. And the normal anion gap is 3 to 12 millimoles per litre, and you can calculate that by adding up his sodium and his potassium minus his chloride and his bicarbonate. So I'll just admit some more people. So I'll just admit some more people now. The cations minus the anions, and what they normally would balance out. Normally the anion gap is between 3 and 12. So his sodium, 128, plus his potassium minus his chloride minus his bicarbonate. And because the bicarbonate is very low, his anion gap is very large. That tells you that there's an unmeasured anion in his system, some sort of unmeasured anions. And there are many different unmeasured anions. So if you've got a lactic acidosis, then you'll have a large anion gap because you've got unmeasured anions, because lactate is an anion. If you've got kidney failure, then you retain phosphates and urates, and they become unmeasured anions that are in the body. But in this case, the unmeasured anions in diabetic ketoacidosis are ketones, of course. And this boy had large ketonuria, lots of ketones in his urine, and of course glycosuria as well. And the ketone bodies that are unmeasured anions in a child who's got diabetic ketoacidosis are acetoacetate, and beta hydroxybutyrate. You don't need to know that, but just to know that the reason for his large anion gap was because of ketonemia, a lot of ketones in his blood. When children have diabetic ketoacidosis, their lactate's sometimes a bit high because they're very dehydrated and they may have reduced perfusion, but that's not the main reason for their acidosis. The main reason for their acidosis is all the ketone bodies that exist in their blood. Right? So to get the picture, this boy had severe poorly compensated metabolic acidosis with hyperglycemia and marked ketonuria. So just to give you a bit of a background, diabetes was very rare in the Pacific and in Papua New Guinea, very rare. But in the last 20 years, cases of diabetes are increasing all throughout the world, in almost all countries in the world, even whether they started at a very low base with the disease being rarely diagnosed, or whether it was relatively more common, diabetes seems to be increasing, and no one is quite sure why that is. It may have something to do with a transition to a modern environment. It may have something to do with a change in the predominance of viruses around the world, because most new onset type 1 diabetes is preceded somewhat by some viral infection previously in the previous couple of months. The clinical features, I should say that type 2 diabetes is also increasing a bit more in children and adolescents, but not so much as type 1 diabetes. In New Zealand, among Polynesian kids, there is a bit more type 2 diabetes, and we're seeing a little bit more type 2 diabetes in children in Australia, but the vast majority of the increase in diabetes is type 1 diabetes, and no one's quite sure why, but it's being seen in all countries. The clinical features of diabetes, just as this boy had, was a period of time, usually of usually weeks, of weight loss and thirst and polyuria, and sometimes vomiting, often vomiting. This boy, Donato, he had vomiting in the previous few days before he presented, and then sometimes confusion and coma. And that's a very late stage, but many children with diabetic ketoacidosis for the first time, when they present, they're quite confused and their conscious state is poor. And I'll get onto that in a minute as to why that is, but it's largely the effect of the hypoglycemia and the fluid shifts, the osmotic shifts that occur with fluid in the brain, and also the marked ketosis and acidosis. I mean, children are really struggling with their breathing, and they're often quite confused. So now, to understand about diabetes, we have to understand a bit about insulin and what it does, because as you know, diabetes is where, at least type 1 diabetes is where the pancreas is no longer producing insulin. And insulin is usually the hormone we need for anabolism or growth. And insulin helps, when insulin helps glucose enter cells, and for glucose to be stored as glycogen in the liver and stored as triglycerides in fat. So if we don't have insulin, as children with type 1 diabetes do, they don't have it, then their blood sugar will go very high, but they also, that's why they lose weight. All the glucose that would normally be being used to be stored as glycogen in the liver and as triglycerides as fats is not available. And so they end up breaking down muscle to generate ketone bodies that can provide energy for the brain. Ketones can be, like lactate, can be an energy for the brain, but in the absence of insulin, that's all you've got, just breaking down of muscles. So when there's insulin deficiency, then what you have is all the counter-regulatory hormones being very active, adrenaline and glucagon and cortisol being very active. And that leads to a failure of glucose to enter cells. You get all the glycogen gets broken down in an attempt to supply energy for cellular metabolism. You get triglycerides being broken down, and then you get new glucose being made in the liver from amino acids and glycerol. And so there's an over influence of the counter-regulatory hormones. So it's a bit like this. If you've got insulin deficiency, then the child has hyperglycemia, and because of the hyperglycemia, they have glycosuria. If your blood sugar is above about 12, then you'll be passing lots of glucose in your urine, and with every molecule of glucose, you have to pass lots of water, right, and other electrolytes. So these patients typically have a deficit of body water. They're severely dehydrated, and they have a deficit of total body potassium. And so in response to all of that, their counter-regulatory hormones start kicking in, particularly glucagon and adrenaline, and that leads to the breakdown of muscle to form amino acids that can form glycogen for glycogen storage in the liver, and the breakdown of free fatty acids also for glucose metabolism, but the breakdown of free fatty acids leads to all these ketone bodies that leads to ketoacidosis. All right, when you've got insulin deficiency, then you have breakdown of fats and muscle particularly, and the effects of that on body metabolism. When you look at the urine of a child who's got diabetes, then you need to look particularly at their ketones and their glucose. The ketones are very important, and part of one of the key aims of treatment of diabetic ketoacidosis is to clear the ketones. Often we sort of focus more on the glucose, but we've got to bring the glucose back to normal, but also clear the ketones. So these children will have high levels of, I'll just admit some more people, these children will have high levels of glucose and also ketones in their urine. Diabetes occurs, I mentioned before that there's been an increase in diabetic ketoacidosis around the world, in new onset type 2 diabetes around the world. And diabetes occurs because of some sort of autoimmune destruction of the beta islet cells. It's not the whole pancreas that is destroyed, but it's the beta cells in the islets of Langerhans. So the exocrine function of the pancreas is preserved, but the endocrine function, the insulin production is destroyed. And probably what happens is that some sort of viral infection triggers off an immune response, and it's usually a T cell lymphocyte infiltration into the islet cells, and it's usually months or weeks or years before. No one quite knows just how proximal the viral infection is, and I think it varies from child to child. There's probably some genetic susceptibility too that makes some children, when they get certain viruses at a particular time, be more likely to produce antibodies that then attack the islet cells, the beta cells in the islets of Langerhans, and destroy the cells that produce insulin. There's these days we can measure lots of islet cell autoantibodies and anti-insulin antibodies, and for children who have type 1 diabetes, sometimes we measure them, and almost always those islet cell autoantibodies are present. You don't need to measure them, but it just tells you something about the pathophysiology of the onset of type 1 diabetes, that it's probably a viral infection. It used to be, no, in fact, it still is, that a lot of children who have type 1 diabetes have antibodies to Coxsackie virus. And so there are certain viruses that are a bit more prone to triggering diabetes, probably enterovirus and Coxsackie virus, and they just produce a diarrheal illness or respiratory infections. And so that's they're the viruses that commonly we find, but they're not necessarily the ones that are always causing it. So just to summarize the pathophysiology, because if we understand the pathophysiology, we'll understand how to treat these children. I think that when you get insulin deficiency, you get hypoglycemia, that leads to glycosuria and dehydration. You get fat and protein catabolism. So it's all the fat and the protein is being broken down. That produces ketone bodies, and that's why you get acidosis. All right, the ketone bodies provide the body with energy. They can enter the Krebs cycle, and they can be involved in ATP generation, so that you get cellular function, but that just produces a severe acidosis, a ketoacidosis. There is dehydration from vomiting, from the osmotic diuresis, from glucose, hypoglycemia, and ketones, and part of the acidosis is because of dehydration as well. So I said most of the dehydration is because of the hypoglycemia and the osmotic diuresis, but some of it's because of vomiting and other things. All right. As I said, the potassium in all children with diabetes is low. Sometimes it's not measured low. So you might measure the potassium and it'll be normal or high. And that's sometimes because the kidneys have stopped working. Like if a child's in really severe diabetic ketoacidosis, they'll be so dehydrated, their kidneys have stopped working. And so you should, the point is you should never start potassium in a child with diabetes until they start making urine. When they're making urine, then it's quite safe to start them on some extra potassium if their potassium is normal or low, because their whole body will be deplete of potassium. But you need to ask them if they're passing urine and see how much urine they're passing before you start them on potassium. The aims of treatment of diabetic ketoacidosis are to correct shock if it's present. So we normally correct shock with a bolus of fluid of something like 10 or 20 mils per kilo of normal saline or Hartmann solution. Either of those is okay. You shouldn't give too much fluid though, and the child looks very unwell and they look very acidotic, but it's different to a child with sepsis and dehydration who might be able to cope with 20, 40, or even sometimes 60 mils per kilo of fluid. You shouldn't do that to a child who's got diabetes. And the reason for that is because when the acidosis of diabetic ketoacidosis is not so much because of the profound dehydration, but it's because of their ketoacidosis. And if you give them too much fluid because you overestimate the degree of dehydration, then you might cause cerebral edema. And so I tend to give patients who have signs of shock with DKA, give them 10 or 20 mils per kilo, and then start them on their dehydration fluid regime, rather than just giving them boluses of fluid, which can be dangerous. You should use an isotonic fluid, and what all that means is that it should have a sodium level that's similar to plasma. So you know the sodium level in plasma is 135 to 145. So you should give a fluid that has a sodium level that's similar to plasma. You can use normal saline if you want to, but Hartmann solution is probably better. And the reason it's better is because normal saline is an acidic solution. It's got a pH of less than 6. And so when you give normal saline to patients who've got a severe acidosis, sometimes their metabolic acidosis doesn't correct. And so that's why I tend to use Hartmann solution or some other balanced salt solution. Now, as I said, there are pitfalls in estimating the degree of dehydration. And just because a child's severely acidotic and tachypneic doesn't mean they're very dehydrated. Usually they're quite dehydrated and you need to correct their severe dehydration, but don't keep giving them boluses of fluid because of the risk of cerebral edema. You do need to replace their potassium deficit. And usually once they've started passing urine, I'd put in 40 millimoles per litre in the rehydration fluid. If their potassium is very low, then put in 60 millimoles per litre. And then calculate their rehydration volume. I'll tell you about that in a minute. And then we can commence insulin. And there's two ways to do this. And the way that's most commonly done, and this is the way this young boy in PMGH had his insulin run this week, and that was with an insulin infusion pump. If you're lucky enough to have insulin infusion pumps, then the average amount, we always start the insulin at 0.1 units per kilo per hour. All right, 0.1 units per kilo per hour. And some children with diabetic ketoacidosis, they don't need quite that much because their blood sugar drops quite quickly, especially if it's the first time they've been diagnosed with DKA, their first diagnosis of diabetes. Then sometimes they don't need quite that much. But I always start them on 0.1 units per kilo per hour, and then watch their blood sugar fall in the first hour or two. And if it's falling too quickly, then I cut the insulin back to 0.05, so 0.05 units per kilo per hour by continuous IV infusion. And usually what you do is put 50 units in 50 mils. So every mil per hour, 1 mil per hour is 1 unit of insulin, and you can work it out based on the child's weight. So a 15-kilo child, if you run it at 1.5 mils per hour, they'll be getting 1.5 units per hour, which is for a 15-kilo child is 0.1 units per kilo per hour. Okay, so you just need to do the calculation and then have somebody check it, because it's very dangerous if you get the calculation wrong. But usually 50 units of insulin in 50 mils of fluid, 50 mils of normal saline, and put that in the syringe driver. And they should only be, most children, remember, you shouldn't be running the insulin at like 10 mils an hour. It's usually about 1 or 1.5 mils per hour. Okay, so if you have to run it at high rates, then maybe you've got the calculation wrong. The other way to do it is to give it subcutaneously, and this can work too. And if you're I've been in situations where I haven't had infusion pumps, and in that circumstance, you can run up to 1 unit per kilo per day divided by 6. So you give subcutaneous insulin every 4 hours, and you start with about 1 unit per kilo per day. Either way, you have to watch and see what rate the blood sugar falls, and then you have to adjust the amount of insulin you give. I'll talk about what's called a sliding scale in a little bit of time. But this boy we talked about got 0.1 units per kilo per hour, and that brought his ketosis under good control. His acidosis came under good control over about 48 hours. You shouldn't try to rehydrate patients with DKA over a short period of time. Try over about 48 hours is usually about right. Okay, so when I get a child with diabetes, I always just get out a piece of paper and write all the calculations down. And this is what I did for one child. So a 7-year-old boy with DKA, he was 20 kilos and he was quite dehydrated. So you can predict that he's about 10% dehydrated. So you can calculate what his maintenance is and what his deficit is, and then you can work out the volume of fluid that he would need. And so if a child is 10% dehydrated and they're 20 kilos, then remember that for the first 10 kilos, it's 100 mils per kilo, right? 1,000 mils. For the next 10 kilos, it's 50 mils per kilo, so another 500 mils. So his total maintenance would be about 1,500 mils over 24 hours. So that's the deficit for a 20-kilo child, right? Sorry, that's his normal maintenance. The deficit is 10% of 20 litres. Remember, a 20-kilo child is roughly 20 litres of fluid. And so that child's deficit is about 2 litres, all right, 2,000 mils. So then you've got, if you want to replace the deficit over 48 hours, that's 1,000 mils per day, and plus his maintenance is 1,500 mils. So his maintenance fluid is, you divide that by 24. So 1,500 mils over 24 hours by 24, you get to 63. And his deficit is 2 litres divided by 48. So 2 days is 42. And the reason to go through this sort of calculation is that it often surprises people just how much volume a child requires. So this is a 20-kilo child, but he needs 105 mils per hour for 48 hours to replace his deficit and to correct his dehydration. So it's important to do those calculations. And if you have trouble doing them, then ask someone else. Okay, and for this child, we gave him, this is another child, not Donato, but we gave him 1 unit per kilo over a 24-hour period, right? So 20 units per day, divide that by 6, so you get 3 units every 4 hours. And then that's a reasonable starting point, 3 units of insulin every 4 hours. And that's a good starting point. And then you have to adjust up and down based on what his blood sugar does. The type of fluid, as I said, it's ideal if you can give Hartmann's solution. You need to add some potassium chloride to that, all right? So usually 40 millimoles of potassium chloride. And remember, in a 10 ml ampoule of potassium chloride, there's 13.4 millimoles. So you add roughly 3 ampoules to that. That gives you about 40 millimoles. So 3 ampoules of potassium chloride to 1 litre will add 40 millimoles of potassium chloride, right? So just important to do these calculations and then ask somebody else how to check them for you. Right? So the aims of, it's important to understand the aims. I talked about this before, but we need to correct this child's dehydration. We need resolution of his acidosis and resolution of his ketosis. We need his blood sugar to fall, right? And when his blood sugar starts to fall less than 12 millimoles per litre, then typically we add glucose to the hydration fluid. And the reason you do that is do that rather than stop the insulin. Don't ever stop the insulin in a child with DKA, because they'll just become acidotic and ketotic again. If their blood sugar is getting lower, then add more glucose, okay? All right. Over the time of correcting this boy's or this child's dehydration, their sodium level should increase. Remember, his sodium came in at 128 when he started, but that should increase, and it should increase but to a high normal level, to 145, about 145. If it doesn't increase, then what that means is his osmolarity, his serum osmolarity, will be dropping a lot, right? Because when you treat his hypoglycemia, you drop his blood sugar quite quickly, and that drops the serum osmolarity, and that can sometimes lead to a shift of water inside cells, and that's one of the features, one of the factors people think leads to cerebral edema. So the aim is, when you're rehydrating patients with diabetic ketoacidosis, their blood sugar should fall and their sodium should rise. All right, and that's why you use an isotonic solution like normal saline or like Hartmann's solution. You should also always ask the questions about why this child presented now. All right, because a child who comes in first time with their diabetic ketoacidosis, they might have an intercurrent infection, and the sorts of infections that are quite common in children with diabetic ketoacidosis, staphylococcal infections or urinary tract infections, common sort of infections, and sometimes fungal infections, but usually not. Usually it's like a urinary tract infection or a staph infection that's got in from their skin. Now, not all children with diabetes have such infections, but it's important to clinically look for them. Now, as I said, one of the things I emphasized in terms of identifying, looking for complications when you start treating children with diabetes is that sometimes children with diabetic ketoacidosis it's rare, but they sometimes will develop a bit of cerebral swelling. And in fact, if you do CT scans on all children who present with diabetes, even before you start treatment, you see a bit of some changes on the brain water in all children with DKA, and that's because it's a very it causes a lot of disequilibrium of fluids. But severe cerebral edema is actually very rare, and in fact, most children. I know that this boy recently, Donato, at PMGH, he was thought maybe to have some cerebral edema, but probably his deterioration in conscious state was just his dehydration and his ketosis. Right, but it doesn't hurt to be attuned, to be alert for the possibility that a child might develop cerebral edema while you're treating them, and therefore be cautious about the boluses of fluid you give, and be cautious about making sure that as their blood sugar drops, their sodium level should rise. Right, so they're the things you can do to guard against cerebral edema in children with DKA. And the other thing you can do is not to give bicarbonate. You should never give bicarbonate to children with diabetic ketoacidosis. We used to do that, and then we found that it was probably associated with an increased risk of getting cerebral edema. So now we no longer do that. If a child has some deterioration in their conscious state, then I think it's okay to give them a dose of mannitol, like this young boy this week got. It's okay to do that, but mostly their decrease in conscious state is because of their acidosis, their ketosis, not because of cerebral edema. The other things we sometimes do for cerebral edema won't really work in a child with DKA. So sometimes with a child's got cerebral edema, we might think they need to go on a ventilator and have the ventilator breathe for them. But in fact, with DKA, the child's always breathing at a very high rate, and you can't really match that with a ventilator. So I almost never do that to children who've got, diabetic ketoacidosis. So giving them a small dose of mannitol is okay, but really we just have to push on with the treatment of their dehydration and their ketosis and their hypoglycemia, and usually their conscious level comes back towards normal over a period of about a day or two. Okay. Now, the next phase of management, after you've got their ketosis resolved and their acidosis resolved and they're rehydrated, is to transition to chronic treatment. And this can be as hard as the treatment of children with DKA, I think. It can be actually as tricky. So there's two ways to do it. The first way is to estimate and adjust, and the other way is a sliding scale. Both ways are okay, but I'll go through both ways you can do it: estimate and adjust, or a sliding scale. You can do combinations of both of these things. In fact, we did that earlier this week, but probably a good way is to estimate and adjust, and then estimate what the child's insulin requirements will be, and then adjust based on that. It's important to have an understanding of the types of insulin that the child will be on. So up until now, for DKA, we've been using Act Rapid, which is a rapid onset insulin, and it has a fairly short half-life. But the types of insulin that children will need ongoing have mixtures of short-acting and intermediate-acting insulin. And so one that's commonly available is called Mixtard, which is a 30% short-acting and 70% long-acting. All right, I'll go through the insulin types in a moment. But I just wanted to make a point that some children with new onset diabetes have what's called a honeymoon period. And they have a period after their DKA is treated when their insulin requirements will often be very low, somewhere between 0.2 and 0.5 units per kilo per day. And people might even question whether this child actually has diabetes because they don't seem to need much insulin. And that honeymoon period usually only lasts for days or weeks, but it can be a period of some questioning. People think, oh, maybe we got the diagnosis wrong because the child hardly needs any insulin. But it is called a honeymoon period just because it only lasts a short time. But the point about the honeymoon period is if you estimate and adjust insulin, sometimes you end up adjusting quite to low levels of insulin. And so if you start with like 1 unit per kilo over a 24-hour period, sometimes the child will, they'll be normoglycemic on that, or sometimes even hypoglycemic on that, and you'll have to adjust down rather than adjust up. It doesn't always happen, that honeymoon period, but sometimes it does. So just be aware of that. Okay. The types of insulin, as I said, there's lots of different types of insulin, but you just need to know about the short-acting and the intermediate-acting insulins. And the Mixtard insulin that I mentioned is usually 30-70. Sometimes it's 50-50, short and long-acting. But the Mixtard typically is 30% short-acting and 70% intermediate-acting. The other way is to mix up the insulin yourself, but it's easier if you've got Mixtard insulin. That makes it a lot easier. Remember that 1 unit of insulin of any sort is the same. All right. And so when we talk about units of insulin, a child needs 20 units of insulin per day, then it doesn't matter what sort of insulin they receive, they'll still need 20 units of insulin per day. Okay. The type of insulin that you choose dictates the duration of which it acts for, not the strength of the insulin. All right. And so a child who needs 20 units of a day just when they're getting their act rapid for their DKA will probably need about 20 units of Mixtard per day, right? They'll still need about the same number of units. It's just that you're giving it in a different form because you're giving it in a different way, okay? If you follow the estimate and adjust approach, which I think is usually pretty good, then mostly children will need 1 unit per kilo per day. And sometimes they'll need less. Sometimes it's only 0.5 and sometimes it'll be a bit more. With this boy that we're treating this week, he's at the moment needing 1.5 units per kilo per day. So he hasn't had a honeymoon period and his blood sugars are now just getting into the normal range. So not all children will have this honeymoon period. Typically we give 2 subcutaneous injections. So 1 in the morning, just before breakfast, and 1 in the evening, just before dinner. All right. So usually about half an hour before breakfast or a half an hour before dinner. We give 2 subcutaneous injections. Sometimes people give 3. 3 can be a good regime too, but it's harder. You've got to think what can we do at home? All right. What is possible for the child and the family to do at home? And usually 2 subcutaneous injections is all most families can manage, but they will manage that if they're taught how to do it properly. We give 2/3 of the total dose in the morning. Why? Because the child then eats breakfast and later they eat lunch and then they're active throughout the day. They might even eat some snacks. And then we give 1/3 at night. One, because the child's going to be much less active at night and they only have 1 meal, okay? So 2/3 in the morning, 1/3 at night. And 1/3 of the dose is usually short acting and 2/3 of the dose is usually intermediate acting. And that's why Mixtard is 30/70. So 1/3 short acting, 2/3 or 70% long acting, okay? So that's usually the formula for a starting point for estimate and adjust, right? So this child, this 7-year-old who is 20 kilos, needed roughly estimated at 1 unit per kilo per day or 20 units of insulin. So 2/3 in the morning, 13 units in the morning, of which if we didn't have Mixtard, we'd have to mix them up. So 9 units of intermediate acting, 4 units of act rapid. So 1/3, 2/3, and 1/3 nocte. So that's 7 units at night, all right, roughly speaking. 5 units of intermediate acting and 2 units of act rapid, or just 7 units of Mixtard and 13 units of Mixtard in the morning. So you don't need to mix it up all the time if you've got the pre-mixed insulin, which is really good. You give it in the as subcutaneously in the lateral aspect of the abdomen or in the thigh. Always rotate the location in which you're giving the insulin, so you're not putting insulin into the same skin, the same tissue all the time. Rotate it as you go. The other way to do it is a sliding scale, and sometimes it's helpful to still do a sliding scale as well as estimating and adjusting. And with a sliding scale, you can give a baseline insulin, like it might be 1 unit per kilo per 24 hours, and then measure the blood sugar every 4 hours. And then if the blood sugar is high, then give a bit extra insulin, right? You can give, and so if the blood sugar is 10 to 12.9, the child would get 1 extra unit of insulin. Or if it's 19 to 21, then they'd get 4 units of insulin. And I usually only do a sliding scale for a day or 2, and no more than that. The value of doing a sliding scale is that at the end of the day, you can add up all the insulin the child received, whether it's the Mixtard insulin they got morning and night, or whether it's the extra insulin they got as part of the sliding scale. And that tells you how much insulin the child will need for the 24-hour period, all right? And so it can be one way of finding out the amount of insulin the child needs for the next 24-hour period. But remember, no 24-hour period is the same. And sometimes as children are recovering from their DKA, then they start getting hungry and they start eating a lot. So they might seem to have a high insulin requirement in the first couple of days because they're back to normal and they're hungry and they're eating a lot. So it is a dynamic thing that has to be adjusted every day. And so usually before you give tonight's insulin in this child in the ward, well, I think the registrar should be rung and told what the blood sugar is, and then they should adjust the insulin based on what the blood sugar is. That's what you would typically do for the first few days, even the first week, while you're adjusting the amount of insulin the child receives. Right. Part of the ongoing management of diabetes, of course, is not just insulin, and there's a lot of education required, and a lot of, I suppose, I mean, not all children eat 3 proper meals a day, but you have to start to encourage children with diabetes to eat 3 proper meals a day. And usually I tell them fairly basic things, like everybody understands about junk food, and some of us health workers understand about refined carbohydrates or refined sugars or processed sugars. But I tell children with diabetes, they've got to stop eating these things, right? No more fizzy drinks, no more chips or sweet biscuits, not as a general rule. But think about the complex carbohydrates. They're okay to eat, like whole grains or vegetables and fruits, and bread, which is especially whole grain bread. They're good. All the healthy foods, but not so much the refined foods. Now, this morning that little boy asked if he could have cake again, and of course, occasionally, children can have like a slice of cake or something like that. That will put their blood sugar up, of course, because it's got lots of refined carbohydrates. I just think you should, as a principle, children with diabetes should be eating healthy foods, not junk food. But that's the way all children should be, not just children with diabetes. And the reason for that is this thing called the glycemic index, which I haven't explained this graph, but it's called the glycemic index. And if you eat these junk foods, these refined carbohydrate foods, then your blood sugar rises very quickly and then it falls quickly, right? And so your pancreas has to produce a lot of insulin in that time. So your pancreas is always producing big spurts of insulin. Whereas if you have a diet that's mostly got vegetables, fruits, complex carbohydrates in them, then the glycemic index is quite low. And what that means is that you have a rise in blood sugar, sure, but it's not very abrupt. And so the pancreas doesn't need to produce so much insulin. This is normal people, not children with diabetes. But it's a much healthier way to be. And probably one of the reasons why people or adults get type 2 diabetes is because of the constant exposure of their pancreas to these high glycemic index foods. And so that is part of the origins of obesity and also type 2 diabetes. But if you've got type 1 diabetes, it's better to teach those children to be eating this type of food. Healthy, fresh food is best. All kids with diabetes need to exercise. I mean, there are plenty of children with diabetes who play sports and exercise normally, and they should all be told that they'll be able to do whatever sports they want. And they'll be able to eat, apart from the junk food, they can eat whatever food they want, really. It used to be that, it was highly regulated. You have to think about portions and that sort of thing and weigh out the food. But no, these days, children eat healthy food and they exercise normally, right? You've got to think about how to get a supply of insulin at home. That's often a challenge. Families always need to have a refrigerator because you have to keep the insulin in the refrigerator. They need a glucometer so that they can do regular blood sugar testing. And I always have some urine dipsticks for the patients so that they can check their urine for ketones and glucose. If they're now remember, not all the time, not every time a child gets hypoglycemia will they get ketotic, and mostly when they get hypoglycemic, then they'll deal with it with a bit more insulin. It's only if they have usually when they've got an infection or something like that that you get the ketoacidosis, or when they're first diagnosed. The children with diabetes should be encouraged to keep a logbook, and they can just check their blood sugar every day and record it in the logbook. It helps them, I think, to understand their diabetes really well, and it's a bit empowering, I think. So the children with diabetes will do very well if you teach them to look after their own diabetes, and you teach their families to look after their child's diabetes. So they'll become the experts in their disease, and they'll know what they can do, and they'll be more experts in it than what we are, and that's a good thing. That's what should happen. Now, there's a test called the hemoglobin A1C, which I did notice that the boy this week got. He had his hemoglobin A1C checked at a private clinic, and this is a test of the not so much how your diabetes has been under control in the last few days or a week, but how long it's been over the last few months, how well it's been controlled over the last few months. And it was interesting to me to see that this boy, Donato, his hemoglobin A1C level was 4%. So it was in the normal range. And that tells me that he hadn't had diabetes for too long. It had only been quite a short illness for him. Because sometimes when children present with diabetic ketoacidosis, their hemoglobin A1C might be 8 or 10 or 12 or 14, even very high levels like that. And that tells you that they've been sick for a very long time. It'll be interesting to follow this boy's hemoglobin A1C level every few months or every 6 months to see how good his control has been. All right. So it tells you something about the quality of the control of the child's diabetes. Now, remember I said that over the first few days, this transition period from acute DKA management to the more chronic management, it is dynamic. And as the child improves, they eat more, they exercise more, the insulin requirements are very dynamic. So you just should measure and adjust, and teach the family to measure and adjust as well. Don't forget the honeymoon period. Not all children get it, but if they do, then they are at risk of getting nocturnal hypoglycemia. And this is something that nocturnal hypoglycemia is something that is probably the most feared complication of diabetes, even more so than cerebral edema. The nocturnal hypoglycemia is really important, that we all should focus on. Because if, for example, a child gets, it usually happens, not so much that they're getting too much insulin, but for some reason they might have skipped a meal and they didn't eat an evening meal, and they had their normal insulin, and at 2 or 4 o'clock in the morning, their blood sugar goes low. And sometimes children have hypoglycemia during the day. They have hypos during the day if they're on too much insulin, or they're skipping meals, or they're exercising a lot. But hypoglycemia at night is the thing we fear the most. The signs, you need to teach families the signs of hypoglycemia. So that usually they'll have palpitations, they'll feel their heart rate racing, they may be dizzy or pale or weak, they may have a seizure. All children should carry with them a source of glucose, like some sort of sweet that has glucose in it. Barley sugar is good, that has extra glucose in it, so that if they start feeling these signs of hypo, then they take a barley sugar. If you think a child's having nocturnal hypoglycemia, then it's really important to reduce the nocto dose of insulin and assess their diet, especially their evening meal, if they have overnight hypoglycemia. So for this boy that we're looking after this week, really important that evening blood sugar should be done before his dose of insulin, and then we can adjust he might not need, I think he's written up to tonight for 10 units of insulin. He might only need 7, or he might need 8. It might not be 10, but it should depend on what his blood sugar is in the evening, so that we avoid nighttime hypoglycemia. Right? It doesn't mean we want him to be hyperglycemic, but it just means we want to avoid, the blood sugar being less than 4 or something overnight. All right, that's the most dangerous thing. As I said, education is really important, and you teach parents to be experts in diabetes. If you teach them to give insulin, I mean, this week, this family, the mother and the father and Donato himself should learn how to give insulin. They'll be the experts in giving insulin. They'll be the experts in giving insulin cleanly, drawing it up, where to give it, etc. Remember, when every child with diabetes will have some days when they're a bit sick. They'll have more days when they're normal, more days when they're well, but they will have some sick days. They'll get a virus and they'll feel sick, and they need then on those days, for sick days, more regular testing of their blood sugar. And they need to get used to, when they're, like I said, they shouldn't have fizzy drinks, but if they're sick or they've got any vomiting or diarrhea, they should check their blood sugar, and they should have fluids that are sugar-free. It's okay to give oral rehydration solution. That's fine. ORS is fine because that's got a bit of sugar in it, but not much. But they shouldn't have like Fanta or Solo or lemonade for rehydration. It's very important that they don't, because if they do that, then their blood sugar will definitely go high and they'll go into ketoacidosis very quickly. I've seen that happen often. Children who have some diarrhea and their parents give them lemonade to drink, and that's got too much sugar in it, and then they go into hypoglycemia and ketoacidosis. There are some longer term issues with diabetes, and we won't talk too much about this, but just to know that if you look after your diabetes well, and if a child has reasonably well-controlled blood glucose, then that markedly reduces the risk of getting any of these complications. But these complications still do occur. So every 6 or 12 months, children with diabetes need to be checked to see if they've got any of these complications, right? So you can easily check their urine for protein. That's a simple thing to do. And it's usually the first sign that they're getting diabetic nephropathy. It doesn't usually happen in the first year or so, but after a few years of diabetes, type 1 diabetes, children can start to get proteinuria if their blood sugar is not well controlled. Diabetic retinopathy is important because you don't want children to have new vessel formation and macular degeneration as sort of diabetic retinopathy. And it's the way to prevent diabetic retinopathy is to have very good control. So this is all about protecting children from complications that they might get in adolescence or in adulthood. And I've seen adolescents with the beginnings, early onset diabetic retinopathy, and that's a bit of a tragedy, because with better control, they could have avoided serious problems with their eyes. Diabetic neuropathy is also relatively common, and you should check children for that every 6 or 12 months. Whenever you're seeing children, you should check them for diabetic neuropathy, because I mean, it's common in adults with diabetes, but it also, I've seen adolescents who have the onset of neuropathy. And it's very important, because if you've got neuropathy, then sometimes the child will have cuts in their skin, and they'll get infections in the skin, and that will make things worse. They may get ulcers. So I think you know all about these complications in adults, but they can occur in adolescents who've had poor control for several years as well. The early onset of cardiovascular disease can be prevented by good control. And then, as I said, other issues like hypoglycemia and seizures, probably they're the most important things to think about, just making sure we prevent nocturnal hypoglycemia. And then I think for most adolescents and children with diabetes, you need to have a very positive attitude for them. You need to tell them that they're going to be, they can be normal, they can live a normal, healthy life as long as they understand their diabetes and they take their insulin well. Because it becomes very hard for adolescents if they're stigmatized because of their diabetes, or if they feel chronically unwell, or their parents don't let them go to school, or they, I think mental health issues for adolescents with diabetes are really important. So we need to make it a normal thing. You need to normalize as much as possible and make them experts in their disease, and make them not happy about having diabetes, but give them empowerment to manage their diabetes. And then I think their mental health issues are not as bad. Some skin infections are quite common in children with diabetes. I won't go through them today, but but just to watch out for that, particularly, as I said, rotate where children are getting their insulin injected, so that they don't get it injected in the same place all the time. Otherwise, they'll get lipoatrophy there, and they're particularly prone to staph infections or fungal infections in that area. Sometimes they're also prone to this problem called acanthosis nigricans, which is sometimes you see it in type 1 diabetes that have poor control over time. As I said, the main things are in the early stages, in the first few years, focus on getting the child's blood sugar control as good as possible, and then all these complications will be less likely. Okay. All right. Well, that's all I want to say today. I hope that's been a bit useful. I think we talked about a lot of these issues during the week for those who've been here. But I just wanted to run through diabetes because I think it's useful for us we don't see it very often, and it's useful to refresh our memories about all of this. So I'll stop there, and if anyone's got any questions about management of diabetes, please ask.
Trevor, can you hear me?
Yeah, I can hear Jim.
Yeah. So just a question in the relation to young people and exercise.
Yeah.
And you know, these people who are going to play 60 or 80 minutes of a soccer match, and they're diabetics. I mean, how do you deal with that? How do you tell them to adjust their carbohydrate, their food intake, and their insulin if they're going to do 60 minutes of really hard exercise?
Yeah, well, part of it is they need to be on a diet where they've got complex carbohydrates, which gives them a sort of a constant level of glucose in their body. I mean, the big risk is if they exercise and they've taken their normal insulin and they don't have some carbohydrate loading before their exercise, then they may get hypoglycemic towards the end of their exercise. But I usually tell them that they should have some carbohydrates before they exercise and their normal morning insulin. Check their blood sugar before they start exercising. Always have some barley sugar or some rehydration fluid available during the exercise. I mean, even with with a 60-minute game of rugby or a game of soccer or something like that, they can still come off and they can have a drink and they can sit down and have a rest for a moment and then go back on. I think they just have to learn about their body and what they can do, I suppose. But it certainly doesn't stop other children I know playing soccer or playing football, but they have to have some carbohydrate loading beforehand.
Thanks, Tom.
Hi, Prof.
Yes, hi,
Diana.
Diana, hi, Diana.
Hi. I just want to ask about the sliding scale. When we use the sliding scale, what type of insulin do we use? I mean, what's the best option for using when we use the sliding scale? Yeah,
often we'll use an act rapid insulin as the sliding scale, but it's okay also to use, I mean, typically, if you're going to do a hybrid thing like we did with Donato, where he got some mixed start in the morning, then I think it's act rapid that he needs as part of the sliding scale. All right. And but as I say, I don't think you should use a sliding scale for too long. Just a day or so to sort of work out roughly what, or to be more precise, I suppose, about the amount of insulin a child will need over 24 hours, and then go on to the, estimate and adjust, which is sort of the phase he's in at the moment. All right. I think it can be a bit, I could see that it was quite confusing for the nursing staff to, use the sliding scale too much, eh?
Yeah. Okay, thanks, Prof.
It's also important for the patient that they don't think they're going to need insulin every 4 hours. Like I could see that this boy, he thought, oh, maybe I've got to get insulin every 4 hours, and that's painful every 4 hours. I don't think kids can cope with that for too long, right? So that's why I think the sliding scale, if you're going to do it 24 hours, work out the amount of insulin you give, and then estimate and adjust. Yeah.
Thank you, Prof.
Prof, sorry, I had a question.
Yes, hi, Annette.
About when do we use insulin pumps?
Yeah.
Like,
You know, I didn't know whether anyone had raised that, because these days a lot more children are using insulin pumps. I think they're, yeah, well, they're quite expensive. Two, they need a lot of patient and family education. And three, I don't want to discourage the use of technology and insulin pumps if they're available, but they do need a lot more adjusting and education and technical support than the sort of insulin treatment that we're talking about. And I've actually seen children with severe hypoglycemia from an insulin pump. And I think especially adolescents who are maybe, you know, a bit more prone to skipping meals and maybe not measuring their blood sugar so well. So I think I think they work well for some families, but they're expensive and technology heavy. But they also don't work for a lot of children. And as I say, I've seen, you know, a couple of adolescents who got profound hypoglycemia from their insulin pump, because the insulin pump is supposed to regulate the amount of insulin that you get, and some of them do it very well, but sometimes they, you know, might malfunction as well. So I think I'd be wary about insulin pumps, I think, in most environments, actually. Have you seen them, Annette? Have you seen them being used?
no, I've just seen one of the medical students that came by, and he had one on him. So I was just fascinated by it, but no, we still use insulin.
Yeah. I think that's what we should still do too. I mean, I think there's a bit more checks and balances, I would say, in giving insulin twice a day and adjusting. I mean, some children, you know, in this setting will be able to have insulin 3 times a day, and probably they'll get a bit better control. But twice a day, you know, can work too. But I think there's more checks and balances if you do the basics right, than trying to, you know, be a bit more sophisticated. That's all I'd say.
Thanks, Prof.
Okay. All right. Well, we might stop there. But thanks everyone for coming online and talking about diabetes today. And all right. Thanks a lot.
Thank you. Thank you.
Thank you, Prof.
Cheers.